Welcome to Tell It Like It Is, a publicly broadcast virtual lecture coming to you from the University of Rhode Island. This is your host and moderator, Dr. Norm Barber, an adjunct professor in the Department of Africana Studies. I'd like to welcome those of you who are joining us this afternoon from the Kingston campus and beyond for this critically important lecture and discussion titled COVID-19 in the African American Community. In celebration of Black History Month, this lecture is being sponsored by the College of Arts and Sciences, the Multicultural Center, and of course, the Department of Africana Studies. We sincerely hope this educational program will serve as an intellectual resource for the university community and as a forum for enrichment across diverse academic disciplines. Here with greetings from the university is Dr. Jen Riley, Dean of the College of Arts and Sciences. Dr. Riley?
Thank you, Norm. Good afternoon, everyone, and welcome to our first Black History event this month. I appreciate you taking the time to join us, and I also want to especially thank Dr. Vanessa Queno, the chair of our Africana Studies Department, as well as Dr. Barber for their energies that put this program together on behalf of the department and the college and our co-collaborator, the Multicultural Center. COVID-19, as we all know, has disrupted our lives and our communities. In particular, we surpassed 500,000 deaths this past week, just a major milestone. And we also know it's clear that there's been a disproportionate impact on our communities of color, access to healthcare, access to testing, and now as we're seeing access to the vaccine as it's rolled out. We're fortunate to be joined today by Dr. Carolyn Parks from Temple University so we can better understand this impact on our African American communities in the United States. So I thank her for joining us, and I'm pleased to pass the mic back to our host and moderator, Dr. Barber.
Thank you, Dr. Riley. This lecture could not have been possible were it not for the dedicated faculty and staff in the Department of Africana Studies at URI. Here with greetings from Africana Studies is the chairperson, Dr. Vanessa Queno. Dr. Queno?
Thank you. Good afternoon, everyone, and welcome to the 2021 annual URI Black History Month observance. I want to welcome and honor my esteemed colleague, Dr. Carolyn Parks. We have been friends for many years, and I'm so delighted that she accepted our invitation to be our keynote speaker today. A great amount of gratitude is owed to many colleagues. To the Dean of the College of Arts and Sciences, Dr. Jen Riley, we thank you for your leadership and vision. To Dr. Norm Barber for your incredible energy and organizational skills as you steered the committee, the planning committee for Black History Month this year. To Dr. Ann Salzarillo McGinn, I like to refer to her as the miracle worker because she dares to make possible those things we think are impossible. Thank you for all of your help, Ann. So many others. To Miss Leah Cooper, who has given us her wisdom and knowledge in organizing the IT portions of the events. But I cannot stop without thanking the students of Africana Studies. We're so great for our amazing students who are uniquely prepared to face the challenges of today. I want to also give special recognition to our Africana Studies faculty, Dr. Paul Andrewer, Dr. Norman Barber, Dr. Ray Ferguson, Dr. Gatahi Gatiti, Dr. Emmett Goods, Dr. Angel Green, Dr. Shanette Harris, Dr. Carnell Jones, Dr. John McCrae, Dr. Marcus Nevius, Professor Barry O'Connor, Dr. Joseph Quenu, Assistant Dean Earl Smith, Dr. Rob Waddell, Professor Gerald Williams. Thank you for being such incredible scholars and colleagues in Africana Studies. Thank you to our audience. May we continue to stay healthy and well. It's back to you, Dr. Barber. Thank you very much.
Thank you, Dr. Queno. As a community of educators, scholars, researchers, and teachers, we cannot ignore the importance of understanding why certain demographic populations like the African American community, the Hispanic community, the Native American community are suffering with the consequences of COVID-19. Nor can we ignore the fact that the African American and Hispanic communities are distrustful of the healthcare system because of a history of mistreatment from many medical institutions. More importantly, we could not ignore the fact that despite being disproportionately affected by COVID-19, African Americans are the most hesitant to get the coronavirus vaccine recently developed by leading pharmaceutical companies. Because of these concerns, it is evident that people of color throughout the country and around the world need answers about the complexities surrounding this medical issue, answers to address feelings of distrust, mistreatment, hesitancy, and even fear of getting the vaccine for COVID-19. This is especially true with the African American community, which, more than any other racial or ethnic group, needs public information from our officials to tell it like it is in order to overcome their mistrust of the healthcare system and to increase their willingness to get the vaccine. Here to tell it like it is Dr. Carolyn Parks, Associate Professor of Instruction in the Department of Social and Behavior Sciences at Temple University. For over 3 years, she has been a practicing community health educator, specialist with a passion for helping individuals, groups, and communities to identify and solve their own health problems. Her community research and practice is focused on the development, implementation, and evaluation of community-based and grassroots health promotion and disease prevention strategies for African Americans, disadvantaged and vulnerable populations, and other groups of color on a broad range of health disparities in various settings. Here to join us is Dr. Carolyn Parks. Welcome, Dr. Parks.
Thank you so much, Dr. Barber, and what a great honor and privilege it is to be with you today in this Black History Month virtual lecture. I want to thank my dear friend and colleague, Dr. Vanessa Winder-Quenu, for the invitation and for Dr. Barber's assistance in getting this set up, and all of the folks that Dr. Quenu has mentioned that have been helpful to us to pull together this session. I am very delighted to be here today and to have this discussion, and I hope this will become a discussion. I'll do a summary of some ideas about COVID-19 and its impact on African Americans and other groups, and then help us to begin to think about some of the solutions for addressing those issues. And then at the end, we hope that there will be some questions that you have that we can address in a larger discussion format. I always like to start with these, what I call the COVID basics, because we have sometimes used some of these terms interchangeably, but we need to make sure that we know what we're talking about when we're talking about COVID. And of course, as is noted here, the official name of the virus is the novel coronavirus, or the SARS-CoV-2 virus. And some of you will remember that name from the SARS virus outbreak we had a few years ago. This is a virus that is related to and similar to that virus that caused that major outbreak. But the main basic to remember and to know about this particular virus, as its name suggests, is that it is in fact a new virus, and hence its name, novel coronavirus. That's an important concept to remember, especially as we are listening to and receiving information about the science of the virus. There's been oftentimes in the media and across different venues talk about, how the information keeps changing and we're getting different sets of information. And that is to be expected with a new virus. We are literally learning about this virus as we go along. So both how the virus itself works, how it functions, how it causes disease, how it's transmitted, how it can be mitigated, all of those things we are learning as we go along. So we shouldn't be surprised about that as we are hearing from our scientists on this virus. The other terminology is understanding that COVID-19 is the actual disease that you get from the coronavirus. And it's the disease that's responsible for causing all of the deadly symptoms and sequelae that happen when people, in fact, contract the virus. One other thing to remember about this virus, and this is not unique to coronavirus, is this growing list of mutations or variations of the virus that are beginning to emerge. And we should not again be alarmed about this, because it is simply the nature of viruses. Viruses, it's actually one of the attributes as a microorganism that makes viruses very difficult to control and to treat. For most of our diseases where we don't have a cure, many of them or most of them are caused by viruses. And that's simply because of the nature of viruses as a microorganism. And so they are able to change or mutate, as we say. When they mutate, they change how they may cause infection. They may change how the body is infected. And so again, like the name of the virus, of this being a novel virus, we should not be surprised by the changes that are occurring with this particular virus. And then finally, realizing that we are in fact in a pandemic. And these pandemics usually are once in a lifetime or a person's lifetime experience. And so as you are familiar by now with the fact that our last pandemic was slightly over 100 years ago, the 1918 influenza pandemic. It's been erroneously called the Spanish flu. There was nothing Spanish about that flu. But these are outbreaks that happen obviously in multiple countries, usually various continents, and affects huge numbers of people. The thing to remember about pandemics that I think we really need to embrace and get in our heads is the fact that pandemics are usually multi-year events. And so even though we reference the 1918 pandemic, it actually did not end until December of 1920. So that was an almost 2-year-long pandemic. And it appears like this coronavirus is functioning in a very similar fashion as that flu virus pandemic. As a matter of fact, it's been suggested that we can expect to be in our current mode, even with the vaccine, for our various mitigations that we'll talk about in a minute, clearly through the end of this year and possibly into the beginning and first half of next year. And so with that in mind, we need to brace ourselves and be prepared to continue all of the work that we're doing to prevent spread and transmission. These are the now very familiar symptoms for people that have symptoms of COVID-19. Some of the major symptoms being expressed with many people. However, the thing to remember about symptomatology for COVID-19 is that a significant percentage of people, almost half, but about 40% of people have absolutely no symptoms of COVID-19. And that is incredibly important in that you could be infected with the disease, but because you don't have symptoms, you are transmitted, you still have the capacity to transmit it to other people. And so again, this makes all of our mitigation factors, particularly of wearing a mask, washing our hands, social distancing, and all of those things very, very important. It also makes testing an absolute critical and fundamental factor for preventing the spread and transmission of the disease. So let's look at where we are and what's happening with the virus as of now. if you go to the John Hopkins University has a wonderful COVID tracker, and this data, the data that we usually get, and even what the data that you see on the news is coming from that source. And so it's a very wonderful source for helping us to track what is happening with the disease. And as you can see, we have now reached over 112 million global cases and over 2 million, almost 2,500,000 deaths. As you can also see, unfortunately for us, we are doing worst in the world for our cases and deaths for COVID-19. And this is really a tragic for us, certainly in public health, but as a nation, these are really tragic statistics for us as a nation, given that we are considered to be the most technologically advanced society in the world. We spend the most money on healthcare in the world, almost 18% of our GNP, and yet we are having the largest number of cases and the largest number of deaths due to COVID-19. And so this is something we should be very sober about. And we reached, as we heard earlier, that very sobering statistic this week of reaching 500,000 deaths due to COVID in the United States. And that should bring a very sobering feeling and perspective for us, and even hopefully motivate us to do some of the more work that needs to be done. We also know, as has been stated in the introduction, the various introductions, that populations of color have been and are being impacted most by this disease. And this graph shows very nicely, no matter how you cut it, whether you're talking about number of cases, whether we're talking about number of hospitalizations or deaths due to COVID-19, that 3 of the 4 major groups of color come out on top for this disease. And interestingly enough, within the last 2 months, these figures have actually shifted. African Americans have actually dropped slightly below both Native Americans, American Indians, and Alaska Natives, and the Latino population for both deaths to COVID as well as cases. But as you can see, for all of the groups of color, they are 1 or more times higher than the general population, the white population, for this disease. So it is, as I have been saying, as we said with HIV when it came out, it's now our disease. This is just another way of looking at some of that data, and this also represents the shift. This is the data from early this month, where you can see this dramatic shift that has occurred with Pacific Islanders and Native Americans and the Latinx population now having some of the highest rates of death to COVID-19. Let's look specifically at African Americans, because even though the numbers have dropped slightly, we do know that as a population group, it has been impacted dramatically by this disease on every level and in every way. And the other population group that has been dramatically impacted are people of low socioeconomic status. So populations of color, populations who are of low socioeconomic status are the groups that are running away with contracting and dying from this great pandemic. And these are just some statistics, and actually this next chart shows it a little better, that across most of our states, or many of our states, even many of our smaller local areas, and we'll see in the next slide, where there are, in particular, majority African American populations, they are dramatically, as you can see by these figures, dramatically overrepresented in their deaths from COVID-19. And so just from these 4 states in the city of Chicago, this slide talks about Milwaukee, where the Black population only makes up or comprises 26% of the population in Milwaukee County. They account for over 70% of the deaths due to COVID. And as is indicated in this last bullet, this is a pattern that we see literally across almost every major city and every state in our union. And this is just another representation of this excess death rate that shows the top 20 counties in the United States that have the highest per capita level of deaths. And for 8 of these, as you can see, African Americans are represented as both the largest racial group and for some of the highest rates of death. So this has become, as so many issues have become, a major disease and condition of African Americans. And so the big question always is, why is that? And why has this disease, and it really took, if you remember, very early on, there was a lot, one of the great misinformation campaigns that happened was this myth that African Americans couldn't even get COVID because of the early populations who were impacted, which was largely older Caucasian adults and individuals with pre-existing conditions, certain pre-existing conditions. But to really understand the why for why African Americans and other groups of color and low socioeconomic people are being so heavily impacted, you really have to understand the concept of health disparities in the United States, and in particular, a concept that we talk about in public health called the social determinants of health. But before we look at the social determinants of health, we need to understand that these health disparities have existed forever in the United States for Black people and for Native people as well. As a matter of fact, the data that is available lets us know that these health disparities along a number of fronts, and we'll look at some of these in a minute, have always existed in the United States. And we have been able to document within the last 30 years the extent of these disparities. So the fact that there's this dramatic disparity is not a surprise. As a matter of fact, those of us who have worked in this area for a long time were not surprised at all to see COVID join this list of health disparities that Blacks and other groups have suffered from. So this concept of social determinants of health, this is a major concept within our work in public health. And this concept helps us to understand both why, how, and where disparities come from within a society, and obviously in our case, within the United States. And the social determinants concept suggests that where people live, where they are born, where they work, where they play, how they age is a reflection of the social and physical environments in which they live. And so as a result, there's this whole range of factors that we know impact people's health, their health status, their ability to function within their health makeup and their health arena, their quality of life, outcomes, and abilities. All of these things are impacted by this host of factors that make up a person's environment, both physical and social. And these various factors are believed to be, particularly their interactions, are believed to be responsible for most of the health inequities that we see within our country or even within a society. And those determinants and those factors are driven by, shaped by how money, power, and resources are distributed within a community, within a population, within a nation, and obviously within the world and across societies. And certainly we see this very clearly when we look at health status globally. We know that what we consider to be resource poor countries have lower rates of health status and health possibilities than do research rich countries. Although again, that does not fully apply to the United States as one of the most resource rich nations, because even though we are spending the most on healthcare and have the most technology for healthcare, we are not the healthiest nation in the world as a nation. We come in somewhere between 20 and 25 on all of the social and health indicators. So even though money and power and resources are part of this equation, it's not always necessarily representative of how the health status of a population, of a nation in particular, will be. But basically, how all of these get distributed, who it gets distributed to, who has the power to control these resources, are all things that impact the health of populations. And this is just a nice visual graphic of how these various factors work. And these are the 5 major pillars of the social determinants of health. So your neighborhood, how your neighborhood is structured, whether or not you have health care and have access to health care, and the quality of care that you get once you get there. And we know that for most of these populations of color and poor populations, we are operating in a 2-tiered, some oftentimes 3-tiered system in terms of the quality of care that people get. Your community, the social makeup of your neighborhood and your community. We now know, we can tell what your health status is going to be, what kind of life expectancy you can have, that you probably will have, simply based on your zip code, where you live. We can tell a lot about your health and how long you may live. And then, of course, the dual impacts of both education and economics, we know, play a major role in terms of the social determinants of health. And this is just a broad listing, not an exhaustive listing, of these social factors that we know play a major role in the health of populations and communities. And several of these we have just talked about. So people's access and availability. A huge factor in many of these neighborhoods is something as simple as the availability of grocery stores. So do people have the ability to go to a grocery store that's close to them and be able to purchase the healthy foods that we know will impact their well-being? Issues of residential segregation is emerging as a huge issue in terms of where we crowd and place people, especially according to socioeconomic status, and the whole issue of gentrification that has emerged in the rebuilding and restructuring of our cities. So all of these various factors, whether you're exposed to crime, the kind of transportation you have, do you actually have transportation to get to a doctor or to get the COVID vaccine? All of these things play a role in people's health. And then, of course, the physical factors that we just talked about, both the natural environment, whether or not you have access to green space, whether or not your sidewalks are functional. Some communities either don't have sidewalks or have sidewalks that are so impaired that it makes it difficult for them to walk or to ride bikes and those kinds of things. Many of these neighborhoods we know are targeted sites for all kinds of toxic substances and other hazards that people may experience. So this combination of social and physical factors, and this chart is just another great representation of that, we know impacts all of these health outcomes that we see at the bottom. So people's mortality, how long they live, what they die from, their morbidity, the kinds of diseases that they get, their life expectancy, how long they can expect to live at birth, how much they have to spend on healthcare and how much they can spend, their health status, as well as their ability to function within a health context. And the World Health Organization summarizes all of this very nicely. And you can, when you get the slide set, you can take some time to read this long quote. But essentially, they are suggesting that the health inequities, the health disparities that we do see are caused by this unequal distribution that we've talked about, whether we're talking about services, goods, income, power, and ultimately sets up a whole system of unfairness that contributes to these social determinants and conditions that people live under, and hence puts them at higher risk for disease and disability. And mostly what we're looking at when we're looking at these determinants are how they interact. And so if you have a low education, if you haven't been able to pursue a higher education or to complete high school, that's going to impact the kind of jobs that you are able to get. And the kind of job that you're able to get is going to impact the kind of neighborhood that you're able to live in, and the kind of house or apartment that you're going to be able to afford, and whether or not you can keep up that apartment. And then the kind of job that you have may put you at risk for all kinds of occupational exposures, especially if you're considered what we used to call unskilled workers, a whole host of jobs where people are exposed to all kinds of things. So we're looking at, in these social determinants, how these various things interact with one another to create poor health outcomes for populations. And this is one of my absolute favorite slides that I use a lot in a lot of different contexts. But this pie chart shows us that the impact of these social and economic factors that we've just talked about. I am a proponent of universal health care, hoping to get it one day in the United States. We're the only country in the world now, the only industrialized country in the world that does not guarantee health care for all of its citizens. That's a disgraceful statistic for us. But even if we got that squared away, even if we got everybody health care and they got into clinical care and we improved access and we improved quality of care and all of those things, that would only impact people's health by about 10%. As you can see, the bulk of influence on people's health is this host of social, economic, and physical factors that we have talked about. And of course, with the impact of people's health behaviors. And we really should have an arrow here because this 40% heavily impacts this 30% of people's ability to actually carry out positive health behaviors. And again, this is just another way of looking at this distribution factor again, that when we see poor health, when we see disadvantages, it is a reflection of how these advantages for some groups and disadvantages for other groups have been meted out. And these inequities are very much systemic. Some of them are by design. And we know that you're far more likely to experience some of these obstacles to one's health if you are from one of these groups that has been historically and systemically discriminated against. And you can pull any one of these lists, any one from this list, to show where and how these various attributes are expressed in health disparities across any number of factors. And this is just one example, using the issue of HIV. So African Americans comprise 13% of the population, but we now make up almost half of all of the HIV cases, as we just saw with COVID. And again, bringing home the point again that these disparities have existed and continue to exist within these populations of color. And this is just a small sampling of them. Heart disease, hypertension. African Americans have the highest rate of hypertension of any population groups really in the world. About 40% of African Americans are believed to be hypertensive. Certainly diabetes is huge for both African Americans, Native Americans, and Latinx populations. So these disparities have been in existence all along. And I'm going to whiz through these last slides so we can get to our questions. Understanding that backdrop of the social determinants of health helps us to clearly see how coronavirus happened and how African Americans and other groups of color have come out on top for coronavirus. COVID-19, as I said earlier, has simply joined the list of long health disparities and health conditions that these groups have experienced. And the nature of COVID really became a great firestorm for creating the conditions for which COVID-19 would be developed. We mentioned low socioeconomic status as being a major risk factor. And so all of the things that go along with that, particularly as it relates to education, income, and occupation. Another major risk factor, specifically as it relates to COVID, is the living conditions of many African Americans and other groups of color, so that people could not, given their simple living situation, could not social distance and physically distance from one another. One, because more per person, populations of color house more people in their homes. By and large. And so the opportunity to be able to physically distance from one another for many populations and many families is almost impossible. When you combine that with this whole issue now of what we have come to call the essential workers, and isn't it wonderful that we now know and accept that our bus drivers, our janitorial staff, our grocery store stockers are somehow now essential workers. They have always been, but COVID has actually brought to light the importance of these workers. And individuals who work in these fields are usually largely, not exclusively, but largely people of lower socioeconomic status and in occupations where they did not have and do not have the option to work remotely, as many of us have had the opportunity to do. And so simply by being out and about in the public, still serving the public during the spread of the virus, exposed many of these populations very early on to the virus. They in turn are bringing the virus home to their crowded housing and living conditions, and thus spreading it from person to person. There are reports of, particularly in both some Latinx and Native American families, anywhere between 12 and 15 people all living in the same house, all being infected by the virus. We also know, we mentioned the issue of inconsistent healthcare, our two-tiered system, and so that especially early on, there seemed to be much inconsistency in how African Americans and other populations of color were being admitted for their symptoms in relation to COVID, or they were being told, wait until you're really sick and then come back. And so many people were getting in far too late for care. Another major factor, we talked about this long list of chronic health conditions. COVID appears to have a great affinity for people that have these major conditions of diabetes and heart disease and hypertension and asthma, which is huge among African Americans, and obesity. So with these pre-existing conditions, it has predisposed African Americans and other groups to these conditions. I've been saying that COVID, given that its impact on the immune system, that we have been walking around, Black folks and groups of color and low SES groups are walking around with a diminished immune system already because of the levels of stress and racism and discrimination that we experience. And so as a result, with an already compromised immune system, it has also predisposed us to the impact of COVID. So what do we do? And then we'll get to our questions. You're all familiar with these mitigations. Please don't stop them. Even after you get the vaccine, which we hope you will all be getting, these will need to be continued for quite a time even after we are vaccinated, until we reach a level of herd immunity within the population in order to reduce the continued spread. Couple specific things that we can do. We need to educate Black people clearly about what this disease is all about and help them to understand this is not Tuskegee. Tuskegee still keeps coming up, but this is not Tuskegee, and nor is it even similar to Tuskegee that has happened. We need to acknowledge that fact and people's fears related to that, but we need to make sure that we are giving people proper information. And that information needs to be literacy appropriate. So we learned very early on that Blacks were misinterpreting the whole social distancing terminology. They were thinking that social distancing meant you could still gather with people that you're usually social with, even if that meant people who were not in your personal and immediate pod. And so we changed that terminology to physical distancing to hopefully help people understand what we're talking about. We continually need widespread testing on various levels and in various locations. And we now need to educate people about the vaccine. And when you get this slide set, this clip is for a little information blurb on these 4 African-American scientists, all under the age of 30, who are at the helm of this COVID-19 research. We need to make Black people aware of that fact, that there are Black researchers involved in this effort. And Dr. Kizzmekia Corbett, as a matter of fact, was the leading researcher on the Moderna vaccine. And so, and we'll probably talk about that a little more in the discussion. And then finally, we need to advocate on behalf of Black people in relation to COVID. This is one of our sheroes in Philadelphia, Dr. Alice Stanford, who created the Black Doctors COVID-19 Consortium of Philadelphia. And she has single-handedly taken on both COVID testing and COVID now vaccines in the African-American community at a point where there was no plan for reaching the vast number of audiences that need to be reached for this population. And then this is the final slide. These efforts need to occur across this spectrum of our neighborhoods and communities and society. So we're not just interested in addressing people at the individual level, but we need strategies along all of these entities in order to help people to recover from the ravages of this great pandemic. And I'm going to stop there so we can have our questions. Thank you very much.
Well, thank you, Dr. Parks. We enjoyed that very much. But you know, one of the determinants of health that you had talked about is this whole aspect of education. There seems to continue to be a great deal of misinformation and disinformation in the African American community around the issue of COVID, around the issue of the vaccine, around the healthcare industry itself. How can we address this issue of providing correct information so that the African American community in particular can make the best decision possible in terms of getting or not getting a vaccine? So
that's a very good question and a very important question. I think it's twofold. One, we need, as I said, we need more accurate and targeted, even in our mass media campaigns need to be more targeted for African Americans and these other communities. We know just from a social marketing perspective that messages work best. They are specifically targeted for the populations that we're addressing. So these kind of general messages of, get tested, get a vaccine, they generally do not work for populations of color and poor and low SES populations. So we first need our mass media campaigns to be more and more targeted. The other that we need to spread and to address the education issue is that we need our institutions, our trusted institutions, and our trusted professionals literally to take this on. And that's part of what Dr. does, in addition to actually providing the services of testing and vaccine. Their doctors also run various educational workshops at the community level. So we need our churches to get involved, churches in particular, which are still the most trusted institution in African American communities, pastors being at the helm of creating these messages, our civic leaders. We need a host of our leaders who are trusted individuals to help us to get the message out and to help resolve some of the myths that are still out there about the virus.
thank you. One of the things you mentioned is that you talked about some of the leading researchers in this field who happen to be African American, but there are college students across the country who are also interested, perhaps, who are in getting involved. How can they do so? They may not be researchers, they may not be at the publication stage, but maybe they're interested in researching and helping to get involved in this process. How can they go about doing that?
That is a wonderful question. And I encourage all of our budding scientists. There actually is on the NIH, the National Institutes of Health, which is our major research arm of the U.S. Department of Health and Human Services. There actually is a link on the NIH page. It's a sign-up link for various kinds of support and involvement for COVID-19. So there's a link for people who are interested in still signing up for some of the studies that are going on. There is an opportunity there's a link for research. So I would go directly to the National Institutes of Health website and sign up for and see what the opportunities are for getting involved with addressing this issue. The other thing I would highly recommend is to find the Alice Stanford's in your community and in your neighborhood and link up with them as another way of getting involved at both the research and practice level.
Very good. Thank you. Now, there's been some argument in regards to wearing and not wearing masks. Some appear to be more effective than others in terms of preventing the spread of the disease. What would you suggest in terms of wearing, not wearing, or what mask is most effective, if you can tell us that, in the stop of the spread?
Well, unequivocally, my recommendation and advice and support is for the wearing of the masks, simply because we do know that the masks are very helpful in helping to lower the transmission rate, simply because your mouth and your nose are covered, you're not able to emit as many of the particles, obviously, that are emitted from nose, mouth, breathing, etc. And so, very early on, there was, again, back to one of the first slides of us learning as we go along. Some of the early advice was that you really didn't need to wear a mask. As we have gone along, we have come to find out that actually wearing a mask is probably, next to the vaccine, the second highest thing that you can do to prevent transmission. So absolutely wear a mask. The most effective masks are the ones that healthcare workers want, the KN95 mask, which is believed to contain most of the particles. However, the most recent recommendation now suggests that double masking is equally as effective, particularly if you're using a cloth mask. The surgical masks, the light blue ones, they actually are very effective as well. But the most current recommendation now is suggesting that we do, in fact, double mask as a way to lower the transmission even further.
Thank you. I understand we have some questions from our audience. Leah, would you like to lead us to that? Here's one. Since transportation to large vaccine sites remain a huge problem, when will the vaccine campaign start using churches to make sure everyone has the option to get vaccinated?
Thank you, Jody. That is such a wonderful question. And I've been referring people to President Biden's specific plan for addressing COVID-19 in communities of color and communities that have been most affected. And part of that plan, part of that national plan, is to establish the combination of both testing and vaccination sites right in neighborhoods that are and have been most affected. And as a matter of fact, here in Philadelphia, we just opened our first 3 neighborhood sites, one in a Martin Luther King Community Center, one in a church, and then the other is going to be in one of the major sports venues. And so, it's believed that these venues will help with the transportation issue. And it was a wonderful report on just the other day of in a neighborhood where people didn't, a low SES neighborhood where people didn't have cars. The transportation service was very slow and inconsistent in that neighborhood. And they set up in a community center, in that neighborhood, vaccination distribution. And in talking with several of the residents, they said that that was the only way they could have ever gotten the vaccine, because it was right in their neighborhood. So part of the distribution plan, part of the Biden plan, is to have states and cities in particular open up these various sites right in the neighborhoods where the virus is most, or where the people, among the people where it is most impacted.
Very good. I understand we have another question from the audience. Please comment on the California excess death study describing COVID deaths by race and occupation, which showed greatly increased deaths among African Americans in frontline and in-person jobs.
Yeah, this is one of the very unfortunate things that we have come to learn. And again, as I mentioned in the risk factor chart, that we have come to learn that occupation has played a major role in the spread of COVID, especially now among these groups of people that we have come to call essential workers. And so just by nature of their jobs, by being a bus driver or janitor, in our nursing homes and hospitals, janitorial staff, even the nurses' aide caregivers in many of our nursing homes, where people have been exposed to the virus on a regular basis, have in fact been impacted and have led to many deaths. And so now this issue of essential workers has become a major issue among us. You remember there are several outbreaks and a couple early on in the food packing industries in North Carolina, I believe they were, where massive numbers of the staff were infected. Hundreds and hundreds of staff were affected. And so we need specific strategies now to address those populations, to ensure that as they are going about their work, they are protected. So yes,
I think we have one last question.
The occupation factor has emerged very large in COVID. Yes.
Very good. I think we have one last question from the audience.
Mm-hmm.
Can you comment on which states are prioritizing vaccines for PLC and low-income individuals, particularly as it relates to different phases of vaccine distribution?
That's a great question. I don't have the exact answer to that. One, because we are just now beginning, since we're literally just now beginning the vaccine distribution, states are really just establishing what their distribution policies are. However, we are and have seen that without specific plans, some states are running into trouble, so to speak, by having the vaccines go to what would be considered to be lower priority groups of people and wealthy people over the populations that need them most. And so states are really just now beginning to establish their plans for how they're going to distribute the vaccine within the communities and within the populations that are most affected. I think New York is one that has a specific plan. We are still developing ours here in Pennsylvania. Our city is beginning to establish its plan. California, I think, also has a plan. So it really will vary based on what the state has established already, what it has done already in distribution, and then what plans are going to be put in place. I think the funding of President Biden's plan, part of the funding that areas will get will require that they have a definitive plan for how they're going to do distribution to populations of color and other colors of need.
Very good. Dr. Parks, if there's one point you'd like for us to walk away from your presentation today with, what would that be? What critically important point would you want us to remember more than anything else about COVID-19?
I think the main point, the major point is to, one, understand that COVID-19 is, in fact, a disease that is having major impact on critical and select populations disproportionately. And so our resources, our information, our supplies, our money, all should be targeted in such a way that it affects those people who are most affected. And that we need to be, those of us who are in positions to be able to, we need to be advocates for that. Because on some levels, the distribution of the resources still are not getting to the people that need it most. So another disparity, COVID-19, it's another major disparity, health disparity, amid this long list of disparities that we have. And we need to make sure that the people who are most affected by the disparity are serviced by it.
Very good. On behalf of the university and the Department of Africana Studies and the Multicultural Center, as well as the many who have joined us this afternoon, I'd like to say thank you very much for joining us in this presentation. I'm sure it will be an inspiration to those, especially those who are interested in continuing in research in this particular area. What I'd like to do at this time is to share with you other information that's going on around the university community with respect to Black History Month. There are a number of events that are taking place. Here on February 24th, of course, we've already had the lecture on COVID-19 and the African American community. This evening at 7 to 8:30, there will be discussion on who killed Malcolm X. That's always a very interesting topic because there's so many conspiracies around his killing. And then on Friday, we have the event, the Next Generation, URI Africana Alumni Symposium, the Next Generation. We're going to talk about the importance not just of professions that are critically important for the African American community, but also the importance of education. So please join us for these events. There are appropriate locations that you can find that will reach out to us and to attend this event. Also, let's see. Okay, if you're interested in, if you enjoyed this presentation and would like to make a contribution to the Africana Studies Department, to the University of Rhode Island, the appropriate website is listed. Please do so. We want to thank you once again for joining us this afternoon and hope that you'll continue to be a part of our educational programming throughout the upcoming academic year. So I think that will end it for us this afternoon.